Our next speaker is Dr. David Earle. He's associate professor at Tufts University in Boston and the program director of MIS. And he's going to, rather than giving you the broad picture, focus on one very important aspect of our daily life as surgeons, and that is how to best manage and respond to OR emergencies. He developed the CSTAT program, and he's going to talk to us about the CSTAT program, Best Response to OR Emergency. Professor Earle.
Thank you.
Thanks for coming.
Thanks a lot. Thank you very much, and thanks to the Quality, Safety, and Outcomes Committee chairs for the invitation and the opportunity to talk about this. So here's my disclosures. None of them have any relevance to this, but I too would be willing to take some more if you have some, yeah. So one of the things that we say a lot and that I hear a lot in the operating room about, well, I don't need any help, and I know what's going on. And you could see from the one paper how the surgeons thought the teamwork was great, but everybody else differed from that, and they didn't think it was that great. And it reminds me of this cartoon here. That what's the problem? And there's sort of a big polar bear sitting in the room, and I think we can't see it. When in this study looking at this is from the JCHO that looked at a number of years of sentinel events, almost 2,300 events. 13% of those sentinel events were operative and post-op complications. So right in the operating room, we're getting a tremendous amount of problem, and we don't seem to be doing much about it. So we talked about this. I don't need to mention that, but one of the interesting things is that the errors. Hold on, let me go back here. Can you put that back one slide, please? Please. I don't know how to make it go backwards. There we go. Is that if you look at this, communication, vigilance, team skills, all of those things, this is from Dan Jones's institution. Nobody got 100%. The experts did better than the novices, but we are not perfect, is the point. And we're not perfect. We're pretty good, right? I mean, people get their operations, and we do a pretty good job. This is another study, also from Dan's institution, that looked at the interruptions that happened during an operation. And in the red circle there is the most important part of this open hepatobiliary case, the porta hepatis dissection. And you can see that the top bar is the exits of the nurse from the room. They're most concentrated. The nurse is leaving the room the most during the most important part of the operation. I mean, has anybody ever seen that? I certainly have. That just is completely illogical. One of the outcomes, the conclusions of that paper talked about these were the factors they thought negatively impacted patient safety: handoffs, patient factors, inexperience, hierarchy of staff members, and the multiple competing tasks, i.e. the high workload, was a significant negative detractor from patient safety. And if you look at other things, say errors, wrong site surgery. This is a wrong site surgery data. There's no emergency going on in the holding area. And we can't sometimes even operate on the right extremity or on the right side of the brain or whatever it happens to be. And communication, training, OR hierarchy or lack thereof, which is a more appropriate term, and distractions were all significant in determining wrong site surgery risk. So how do we respond to intraoperative emergencies currently? So, we all kind of say, well, we know what we're going to do. We're going to get some gauze pads and some sutures and whatever we need to do. But what is their plan? What's the rest of the team's plan? We don't know. Nobody knows. We don't talk about it. We talk about what we need. I mean, look at the LA Lakers or any professional sports team for that matter. In this picture, you can see Magic Johnson doing the no-look pass, right? Well, the guy he's throwing it to knows exactly what he's thinking. And there's no emergency. They're just playing a basketball game. Yet in the operating room, when there's an emergency, nobody seems to quite be on the same page. Because in an emergency, you can't quite think exactly. Can we have the audio on for this?
Tiny, what'd you get?
So this guy just accidentally shot his buddy.
Oh my God!
He's stressed, right? He's not thinking clear.
Yes, please help us. I think my buddy, he's dead. What do I do?
Sir, calm down. I can help you. We'll walk through this together. First, I need you to make sure he's dead.
Well, I can do that. Hold on a second. He's dead. Now what?
So, you can see in a stressful situation where you might not use effective communication tools, you may wind up with differing plans. So what needs to be done in an intraoperative emergency? And let's take the example of an emergent conversion from laparoscopic to open surgery. And you don't have to read this exactly, but here's the dialogue, right? The surgeon says they need a 10-blade. The tech turns to the nurse and says we need a 10-blade. She runs out of the room to go get it. I need some lap pads. There's no lap pads around. The nurses come back in. Give me some more lap pads. I can't. I'm counting. The anesthesiologist says I need to get a blood tube. There is no possible way that this can be efficient. And furthermore, it is the most critical thing that's going on. If you're doing a Heller myotomy or a Nissen or something like that, and you get into the spleen and there's some serious bleeding that you can't control even by tamponading it, this is not the kind of teamwork. You need the Magic Johnson no-look pass where everybody is on the same page. So what does the nurse do? She goes out, yells out into the hallway and says, we need some help, and then runs back in. Well, who's coming? I don't know who's coming, and nobody else knows who's coming. And when they get there, what are they going to do? They're going to run around like a bunch of chickens with their heads cut off because nobody knows who's in charge. Is it the surgeon? Is it the anesthesiologist? And further complicating the hierarchy is that the nurses don't have any responsibility to the doctors, to the surgeons. We don't fill out their performance evaluations. They don't answer to the anesthesia department. They answer to the nursing department, which doesn't interact with us, and it's messy, to say the least. And I would also say that what is the official sort of contingency plan for an intraoperative emergency? Well, we have one for a fire. Everybody has in their manual. I have no idea what it's supposed to be, but if you all take the FUSE course, you won't need to worry about that, right? We all know, we all have a protocol for a code blue. You hit the button and a bunch of anesthesiologists show up, but they're not going to help me get my lap pads, the anesthesiologist. So that's maybe good for that, not so good for other emergencies. We've got a malignant hyperthermia one. We've got disaster protocols. They're all in a book somewhere. We don't know what they are because they're low frequency, very high risk events. So we decided that based on the concept of rapid response teams lowering mortality rates in hospitals, that we would have a rapid response team, but it doesn't need to be a medical team necessarily. It needs to be a technically based response team. So we came up with this and used the acronym CSTAT, which has these sort of key things. We have team assignments, a way to activate it. Everybody has very well-defined, narrow roles, and we practice. That's the thing. I'm going to show you this video here, and you can keep an eye on that section of the door during this video. Let's see here. And this is a simulation, by the way, and we're simulating bleeding during a laparoscopic cholecystectomy. And we're in the operating room, by the way. During one of our educational times when the operating room is empty. So it's extraordinarily realistic. So we decide we need to open. First thing the nurse does is leave. She comes right back, and the video stopped. Thank you very much. Anyway, the point is that the tech turns her back to the operative field, et cetera. So we have these ID badges now. This is our fellow from last year, Jenny, EN 75309. We have these on everybody's ID. They're variably stay on or stay off. This is just a picture of what they look like so that immediately we can identify that the nurses are all red and the techs are all blue. And if the nurse responding to the emergency, for example, isn't sure what to do, or even the circulator nurse, all they have to do is turn their ID badge over and look, and there's not very many things to do on there. So they can stay very focused. Everybody knows who to listen to and who not to listen to. And one of the things that I'll say that we've learned is that even though we may not have a unified team, because you don't have to have extra personnel, by going through these exercises and then actually performing it, even when a trauma comes in, people have this concept now. We talked about the culture of safety. We have a culture of efficiency, and we understand that people are stressed with high workloads, so they focus and they listen. They identify a leader. And all of a sudden, that messy hierarchy goes away, and things become a lot more smooth. And so that's really kind of the main thing. We've presented this at the AORN meeting and the ACS. For future directions, we think that this can be applied to obstetrics, emergencies outside patient care areas, such as the waiting areas and the hallways and whatnot, and in the radiology suites, which we actually did and identified a whole host of things there. So I'll end it there, and thank you very much for your attention.